Hey folks, Scott Weingart here, and this is an EMCrit podcast. This is the first podcast of 2026. And I'm sorry this is a little late. The beginning of the year is always a super busy time, but hopefully it'll be worth it. And so why don't we dive right in? After a very quick mention of the Awake and Aware course, we're going to stop selling tickets in about 3 or 4 weeks, even though the event's not for another month and a half, because we have to know exactly how many people are coming. So if you're thinking about doing this, now is the time. It is going to be an incredible conference about getting joy, about eliminating burnout, about finding your purpose. The tentative schedule is now up on the site at Awake Aware Conference. That's one word, awakeawareconference.com. So if you're at all interested, go to that site, check it out. And if you want to come, you better buy a ticket now, because very soon we're going to stop ticket sales and then you'll be SOL. So awakeawareconference.com, Scottsdale, Arizona, March 1st to 4th with myself and a bunch of my coaching buddies, and you will love it. Okay, so let's get right into the show. I figured since it is JanuAIRWay, trademark Medicine LLC, that we would do a state of the airway. There's been a lot of developments, a lot of stuff brewing over the past few years. I figured we'd just do a reset of where I stand, and then I could hear if you differ with me and you have places that you think I should go differently in my practice, and we'll just see where we're at. So we're just going to do state of the airway for 2026, and it should be a fun show. So as a guiding basis for talking about this, I'm going to use the brand new Difficult Airway Society guidelines out of the UK. They're pretty good. The DAS is getting better and better. There's a few things I quibble with, but for the most part, they're pretty good. So we will use those as our kind of table of contents to what to talk about. And so the first item on the list is Difficult Airway Assessment. Now, I think this gets downgraded in terms of importance for most ED docs and critical care docs. And in some rationales, that's not such a difficult reason to see why, but in others, I think they should be doing at least something. Now, why are they downgrading compared to the anesthesiologist? One reason is that classically, if you're well-trained and really understand this stuff in emergency medicine and critical care, you're always planning for difficult airway, not as an occasional eventuality. If you're smart, then you're saying every single airway you do could turn out to be difficult. And therefore, we escalate early, numerous discussions about that. We don't wait until try 2 or 3 to bring out the adjuncts like bougie or stuff like that. We're doing it on the first try. We don't do standard geometry, non-video, and then upgrade to standard geometry video. We don't do that. We do everything we can on the first try. And I've really spoken about that extensively on the site of escalate early. So our first try is our best try. You're using all of the stuff. And that means that if there is a difficult airway, we are already in some ways prepared for it. We also, in general, have much more equipment available to us in the rooms we intubate in than the anesthesiologists do. They, in general, will have to go and ask for difficult airway adjuncts, for the video device to be brought to the OR. All of this stuff takes time. While if you're a resus-ready ED, and we'll talk about this more in just a minute or two, all of that stuff should be in the room you're intubating in, which means, again, unpredicted difficult airway is less of an issue for EM and critical care than it may be for anesthesia. And then just our general patient milieu means a lot of the airways are more difficult in general, so we're mentally prepared for that being the case. When things go easy and perfectly, we're like, wow, that was an anomaly, versus when things go really badly in anesthesia, it's remarkable. It's worth remarking on, because 99.9% of their intubations are just really easy for them and routine. So that is, in some ways, why we downgrade the importance. Now, we probably shouldn't. I think you still should be thinking about it. And so how do I think about it? Eventually, and very soon, as you get experience in airway, it should become gestalt for the most part. And you don't have to use acronyms. You just have your general practice of what you're looking for and what you're asking. And then these scoring systems and the acronyms, they fall by the wayside. But those scoring system and acronyms are very good to build your gestalt. So let's talk briefly about it. I'm just going to go through the difficult airway prediction mnemonic, not the one for difficult bag valve ventilation or difficult crike or difficult supraglottic airway placement. So LEMON is the classic one. That's the one they were teaching in the airway course. And that acronym stands for LOOK, which is just getting a general sense of the patient's physiognomy. Evaluate the 3-3-2 rule, which is, can you open your mouth enough to stick 3 fingers in? It should be the patient's fingers, ideally. Can you go from the tip of the chin to the hyoid and get 3 fingers there? Can you go from the thyroid to the mentum and get 2 fingers there. And if you can, then that's okay. And if you can't, then that's potentially predictive of difficult anatomy. The Mallampati score, or the modified Mallampati score, just looking in the back of the mouth, is the patient have obstruction or obesity. Now they're talking about airway obstruction, like epiglottitis or stuff like that, and then obesity. And I think what this one should be in the Lemon score, either those in addition to or just replace them with obstructive sleep apnea. That's far more predictive for me than the obstruction, which makes it obvious that it's a difficult airway. You don't need that to know epiglottitis is something you should think, is this going to be tough or not? And then obesity, I'm not sure if obesity really predicts difficult airway when you position the patient properly. And yes, obesity without patient positioning being proper will be a really tough, near impossible airway, versus if you position them properly, then they're not really any more difficult than BMI matched controls from Rich Levitan's work and my own experience. But obstructive sleep apnea, on the other hand, is one not discussed in emergency medicine and critical care, but really on the radar screen of the anesthesiologist, and it's one you should consider. We'll talk more about that in a second. And then the N is neck mobility, and that one you definitely should be assessing for. So what do? I have them open their mouth, and I just look. I don't stick fingers in there. I have them move their neck, because it's really annoying to realize they have no neck mobility and you didn't assess it until after you try to get a laryngoscope in there. And then I do an upper lip bite test, which is not part of the Lemon mnemonic, but I think it's a great one to do. And you can read about the literature. I have it in the show notes for this episode at EMCrit.org/416. But it just means you ask the patient to bite their upper lip with their lower teeth, and you see how far up they could get. You tell them to go as far as you can. And if they could get at or past the vermilion border, that's great. If they could bite the upper lip but not get to the vermilion border, then that makes you a little tentative. If they can't get those teeth at all, if they can't protrude their jaw enough to get those lower teeth up to their lip, that's problematic. You're going to have very little space in the back of that airway, and that should make you think, maybe we do something differently. All right. Now, we mentioned the sleep apnea. This is one I definitely assess during every sedation, and when I remember, I try to assess this during the intubation as well. And probably the best way to assess that is just asking about snoring. And then the other items on the stop bang score, I've linked to that. You can check it out at MD Calc. And obesity is one of the things that predispose to sleep apnea, but obesity, of course, does not equal sleep apnea. So it's on there, but obesity, again, I'm not sure if it is an independent risk factor. People get very scared of these high BMI patients. And I certainly would consider, just for a second, is this a safe patient to paralyze? But for the most part, the answer is yes, if we could position them well enough to get their ear holes. We'll talk about positioning in just a minute or two, so I won't go through it. But if you can position them well, then in general, you can paralyze them. You might want to take a look with either nasoendoscopy or just ketamine, quick look with a laryngoscope, and then say, yeah, this is going to be easy. And then you could take it out, pre-oxygenate them and paralyze them. But obesity alone, not as scary to me as obstructive sleep apnea. All sorts of airway changes from obstructive sleep apnea that you should worry about. All right. Now, obviously, prior difficult airway is an enormous predictor that it's going to be difficult again. So asking about that is smart. And if they had a prior difficult airway, then knowing why is really helpful. And that should be somewhere in the chart. Now, the best way to get this done, and I don't know who first conceptualized this, but it's entered into the mindset of most of the airway lead type people out there, is the allergy system of your EDR, your EMR, is the best way to handle this. And what you do is you put an allergy, and you put the allergy as difficult airway, right? Because the allergies spring up everywhere. Everyone sees the allergies. And so you put it there as difficult airway. And then all of the EMRs that I know of have the ability to explain what the allergy is. And that says that's what lets you have an allergy to penicillin and then explain it's just a rash versus an anaphylactic action. And then in that explanation, you should be putting, we intubated with a standard geometry blade, and we were unable to see. It was a grade 4 Cormack-Lehane view, and the patient required being woken up in the operating room and then an awake fiber optic intubation. Okay, and then you say to yourself, maybe if they had video, it would have been different. So then you might do an awake look with video and go from there. On the other hand, if they say we used a hyperangulated video laryngoscopy and still were able to see nothing, that's a patient I'd be scared of to ever paralyze or do anything except a full awake intubation. So that should be there, and you should ask about it, because sometimes it's not in the chart. Sometimes they haven't been at your hospital before, but they have had operations. So it's a worthwhile question to ask. There's another score out there that started to be used in anesthesia, and it's probably better than Lemon, though probably not by much, and it is the Makocha score. Now, Makocha means stepmother in Eastern Slavic languages, I think Polish and maybe Hungarian. Don't quote me on that last one. And you're getting that Disney vibe of the evil stepmother for the evil difficult airway. So what MACOCHA stands for is Mallampati score, 3 or 4, apnea, obstructive sleep apnea. And those two are scored higher than 1. Those are 5 for the Mallampati being 3 or 4 and 2 for the obstructive sleep apnea. All the rest of these are 1 point. Cervical spine limitation, again, the neck mobility. The opening the mouth less than 3 centimeters, again, the 3 fingers in the mouth. Coma, and they say that's because of secretions. That one probably should fall off. I don't know why that's there. They call it hypoxia. They should call it hypoxemia. Yes, I'm a pedant. And then anesthesiologist not being one. They get you a point. And come on, what that should be is like inexperienced should get you a point, not whether you're an anesthesiologist or not. But it was written by an anesthesiologist. So of course, that's how they phrase it. And the more points you have, the more difficult the patient is to intubate. I also have the JAMA Rational Clinical Exam on difficult to intubate. That Rational Clinical Exam series is amazing, and it assigns likelihood ratios to all of these. You can check that out. So what it comes down to, again, is I try to screen because it's on my checklist, so it reminds me, and I told you how I do it. You should be too. But for the most part, if you're resus ready, then anatomical difficulties go down in their importance. They're still very important to figure out because there are some of these, like I said, even having all the equipment, I would not paralyze these patients. But that's probably why we get away with not doing it, but do it. But ask yourself, are you resus ready? The bay you're intubating in should have all of the difficult airway equipment, including at most hospitals, you should have a disposable bronchoscopy setup with a monitor or 2 machines such that you could at any moment switch to a triple setup. That would be video laryngoscopy, bronchoscopy, and the ability to do an immediate cricothyrotomy. That's your triple setup. And that's what you should have the ability to do in your resus bay. Now, that was anatomical difficulty for the most part. Let's talk about physiologic difficulty. Now, I used to say hop. I've expanded it to hopper, ball hopper or laundry hopper. Do people call it hoppers for laundry? I imagine you could, but I guess ball hopper is the conventional one. And just so you remember, the first HOP, where I used to make beer references, is hypotension, oxygenation, and pH. And hypotension means they either are already hypotensive on high-dose pressors or they have the potential to become hypotensive, like any septic patient you intubate. The oxygenation ones are patients who are requiring positive pressure to get a good sat, or you have them on 100% non-rebreather, which is not a device. That's a way of using a non-rebreather. The way you make a non-rebreather 100% is you put it on more than 15 liters per minute of oxygen. Or pH, which is metabolic acidosis being compensated for by the patient's respiratory acidosis. So those are the first 3. Those you might choose to do in a patient awake. You might choose to augment and resuscitate and then paralyze them. You might choose to do a DSI for hemodynamics. Now, the last 3 letters, the PER I'm adding to HOP, these just don't paralyze these patients. Just never paralyze these patients for the last 3. You should do a hemodynamically neutral intubation with an awake, whether topicalized or ketamine plus topicalized.